to our Neurocritical Care Fellowship webinar. Today we have very important pivotal webinar. We are talking about how to read the neuro-language in the ICU, how to monitor our neurology critical care patients. We have very good experts with diversity from different specialties, different countries and continents. We have Dr. Fadel Ibrahim, who is a neurocritical care consultant at Sheikh Zayed Hospital, and also he is a critical care specialist in King Abdulaziz University Hospital. Dr. Kyra Ruba is an expert and very well known in the field, and she is from Genova, Italy. She is BOCAS expert, and her area of interest is non-invasive monitoring of neurocritical care patients. And we have Professor Iman Al-Nasir from Oregon, United States. So here is a brief agenda of our meeting today. So Dr. Fadel Ibrahim is going to give us some case-based discussion for critically ill patients in the neurology service. Then Dr. Kyra Ruba is going to give us about 30-minute presentation about non-invasive monitoring. And Dr. Ashraf Attayar is going to moderate the session and try to help Dr. Kyra Ruba to answer the questions. Without further ado, I'm going to let Dr. Fadel Ibrahim to start by giving us some samples of the Neurocritical Care Fellowship, and also he's going to discuss with us some challenging cases from his practice.
Good evening, everyone. I am Fadel Ibrahim. Today we will take some sample from our fellowship of neurocritical care. This is a case scenario number 1 of a 56 years old male patient with history of hypertension, atrial fibrillation, admitted to our neurocritical care following a ruptured anterior communicating aneurysm, successfully clipped via craniotomy. On post-operative day 5, he remains intubated and sedated. His intracerebral pressure is stable at 14 millimeter mercury. Cerebral perfusion pressure is maintained above 70 millimeter mercury. His brain tissue oxygenation is within the normal range. However, his neurological exam shows new pupillary asymmetry and worsening of the motor response. A microdialysis data was conducted from a microdialysis catheter, which was inserted in the right frontal cortex in the perilesional zone, with giving glycerol of 326, glucose of 16.2, lactate pyruvate ratio of 30, glutamate of 18 micromole per liter. This is an illustration of the rupture anterior communicating artery aneurysm, and this is after clipping. MCQ number 1. What is the most acutely concerning clinical sign in this patient that suggests possible neurological deterioration? A. Worsening of motor response to pain. B. The presence of elevated microdialysis glutamate. C. Pupillary asymmetry. D. New onset of atrial fibrillation with rapid ventricular response. E. Cushing's triad-like hypertension and bradycardia. I will give you a couple of seconds to answer this question. The answer is pupillary asymmetry. What is the answer explanation? Pupillary asymmetry, especially a new unilateral dilated and non-reactive pupil, is the most specific and acutely concerning sign of uncal herniation. This is a neurological emergency requiring immediate intervention. While the microdialysis data we obtain from the catheter, which is option B, confirm a severe energy crisis and excitatory or excitotoxicity, it is a monitoring finding, not a direct clinical sign. A worsening of a motor exam, which is option A, is concerning but less specific. New atrial fibrillation, which is option D, is a common systemic complication due to sympathetic drift overdrive, but it is not a direct sign of neurological declining. Also, Cushing triad, which is option E, is a very concerning sign of a significant elevated intracerebral pressure and the impending brain herniation. However, it is a late sign. Question number 2 on the same case scenario. Which of the following best explains the elevated lactate pyruvate ratio in this patient? Cerebral microdialysis data. Option A, increased cerebral perfusion. Option B, mitochondrial hyperreactivity. C, anaerobic metabolism due to ischemia. D, excessive glucose delivery. E, hyperosmolar therapy. The answer is C, anaerobic metabolism due to ischemia. Our answer explanation is to understand what is actually a cerebral microdialysis. Cerebral microdialysis is a bedside technique used to monitor brain metabolism in a critically ill patients. A thin catheter with a semi-permeable membrane is inserted into the brain white matter near the injury. The fluid mimicking cerebrospinal fluid, CSF, is continuously pumped through the catheter. As it flows past the membrane, small molecules from the brain's interstitial fluid like glucose, lactate, pyruvate, glycerol, and glutamate diffuse in the catheter based on their concentration gradient. This is an diagram illustrates how it works, this cerebral microdialysis. The collected fluid is stored in a microvial and analyzed by real-time using a portable analyzer in the ICU, allows the clinician to detect early signs of metabolic distress like ischemia or secondary brain injury, which our main target is to prevent even before the change appear on imaging or intracranial pressure. The catheter may be placed as a part of a single multi-lumen pulse system or independently placed through a tunneled technique. This is a patient with a cerebral perfusion and cortical EEG, a parenchymal ICP, and microdialysis catheter, which is placed as a single multi-lumen port, and this is his CT. Our answer explanation: early signs of metabolic distress like ischemia or secondary brain injury, even before change appear on imaging or intracranial pressure, can be detected by the cerebral microdialysis. If you can see here, cerebral microdialysis, glucose, lactate, and pyruvate, and the most important is lactate pyruvate ratio. It can be increased in delayed cerebral ischemia 12 hours or 16 hours before delayed cerebral ischemia happens. This is the acceptable or the normal microdialysis number. If you want to compare, this is the danger area and this is the fatal area. If you compare our patient's data with this, you will find our patient in the danger area that needs intervention. MCQ 3 on the same patient. Based on this clinical and metabolic finding, what is the most likely diagnosis? A, hydrocephalus. B, delayed cerebral ischemia. C, rebleeding of aneurysm. D, status epilepticus. E, cerebral edema without ischemia. The answer, of course, is delayed cerebral ischemia, already we discussed before. If you see again, early signs of metabolic distress, ischemia, or secondary brain injury, even before the change appear on the imaging of intracranial pressure, if you see our patient, his lactate pyruvate ratio is very high that need intervention. So the diagnosis is delayed cerebral ischemia or early detection of delayed cerebral ischemia. So we need to take an action and intervention like initiating a vasospasm-directed therapy, optimizing cerebral perfusion pressure based on the cerebral microdialysis trends, consider repeat CT angiography or transcranial doppler, avoid iatrogenic hypoglycemia, maintain cerebral glucose above 1, monitor cerebral microdialysis trend hourly to trend for reversal or worsening. We will now move to case scenario number 2. This is a 58 years old male found unresponsive and is brought to the emergency department and admitted in the ICU. On the scene, they found empty bottles of oxycodone, diazepam, and he was intubated for airway protection. After 72 hours of supportive care, he remains deeply comatose with GCS of only 3, does not respond to any painful stimuli. His pupillary light reflex are sluggish. EEG showed burst suppression. CT scan shows no evidence of hemorrhage, no mass effects or major infarction. The treating team is concerned that the patient may have suffered of severe anoxic brain injury during his overdose incident, leading to a poor neurological outcome. So they request from the neurology to do a somatosensory evoked potential test to help in determining the prognosis. The somatosensory evoked potential is performing, showing the following. The Erb's point potential, which is the peripheral nerve, is present. There is a present action potential. N14 potential, which is the brain stem, is present. Still, we have action potential. But N20 potential, which is a cortical response, is absent. This is no action potential like here. Question number 1. What is the most accurate interpretation of these somatosensory evoked potential? A, the absence of cortical waveform confirmed diagnosis of brain death. B, the findings are consistent with expected severe depressive effect of opioid and benzodiazepines on cortical activity, and the prognosis cannot be determined until the drugs are metabolized. C, the presence of brainstem N14 potential confirms the patient has intact cortical function and will make a full recovery. D, the absence of cortical N20 potential is a grim of prognostication sign that strongly suggests a severe irreversible anoxic brain injury. E, the test is invalid because the presence of sedating drugs. The answer is D, the absent cortical N2 potential is a grim prognostic sign that strongly suggests a severe irreversible anoxic brain injury despite the drug effects. MCQ number 2. All of the following anesthetic agents are not suppressing the somatosensory evoked potential except A is propofol, B is etomidate, C is barbiturate, D is opioids, E is volatile anesthetics. So which of the following, all of the following anesthetic agents are not suppressing the somatosensory evoked potential effect is except E, volatile anesthetics. To understand both questions and to understand our case scenario, we should consider what is normal somatosensory evoked potential. This is an electric signals recorded from the nervous system following peripheral nerve stimulation. Commonly, we are stimulating the median nerve at the wrist or the posterior tibial nerve at the ankle. In the normal somatosensory evoked potential, the signal travels through the peripheral nerve, which is called the Erb's point, spinal cord or brainstem, which is N14, and finally reaches the primary somatosensory cortex, producing the N20 waveform, approximately 20 milliseconds after stimulation. The presence of a clear, reproducible N20 cortical response is a key indicator of intact cortical somatosensory pathway and highly valuable in neurocritical care prognostication, especially in the case of anoxic brain injury. To make it very easy or simple, What is normal somatosensory evoked potential explanation? We will here make stimulation for the median nerve. The signal will travel from the wrist to the shoulder. This is called the Erb's point here in the shoulder. When the signal travels, our aim is to give a signal here in the median nerve and take the signal, receive it in the cortex. So it should pass in some area. From here to here, this is the Erb's point, from wrist to shoulder, from shoulder to brainstem. This is the N14. From the brainstem to the cortex, this is the N20. Either the message to be delivered to the cortex or no. In the norm, this is the normal somatosensory evoked potential. This is the Erb's point. The signal succeed in traveling from the wrist to the shoulder, giving this. And here, the signal succeed in traveling from the shoulder to the brainstem, giving the N14. And here, the signal succeed in traveling from the brainstem to the brain cortex, giving the N20. N is indicating about negative because we have B, which is positive. But here in N20, you should know that N indicates negative. 20 means after I give the stimulation, it will receive after 20 milliseconds in the cortex, or it will receive after 14 milliseconds here in the brainstem, or it will receive after only 9 milliseconds in the shoulder. This is by the logic. In both cases, this is our patient. If you see, he have absent N20. If you compare this N20 with this N20, here there is signal. So this patient supposed to have anoxic brain damage. But here the patient have N14, which is normal, and Erb's point, which is normal. So he have normal peripheral nerves and normal brainstem, but abnormal cortex. The answer explanation for MCQ number 2, which is the normal somatosensory evoked potential are resistant to the effect of all sedatives, opioids, and metabolic disturbance. According to some volatile agents or in high doses of volatile agents, it can be suppressed. So by the propofol, it's unchanged, barbiturates, benzodiazepines, even ketamine enhances the N20, etomidate, and opioids are unchanged. But in volatile agents, they can suppress the somatosensory evoked potential. Thank you. See you next.
Thank you very much, Dr. Fadel, for this very nice presentation with bedside, very informative questions and answers. It's always in mind, before I start introducing Dr. Kairouba, let me thank Dr. Amr Al-Husseini and WICCM and ICOM for hosting this type of meetings, webinars, which are very, very valuable. And today is handling and discussing one of the hot topics in neurocritical care in general, and particularly in intensive care medicine, and more particularly in areas where we don't have very specialized units, but then it is not luxurious for all intensivists not to put in mind that they might not know how to monitor their neurally critically ill patients or brain injured patients, either traumatic or non-traumatic, with a sort or another of knowing how there are the ICP in those type of patients, because there are a lot of devastating complications happens once the intracranial pressure increases. And it's always in mind that invasive versus non-invasive. When it comes to non-invasive monitoring of brain injured patients, the brain monitor with non-invasive tools was found to be very promising, particularly in the field of point of care ultrasonography. And tonight, we have one of the eminent speakers with a lot of researches, a lot of efforts and work on neurocritical care, particularly again in non-invasive ways of monitoring. Kairouba is one of the professors of neuro-intensive care, neuro-anesthesia, and she was the leader of the neurocritical care section in European Society of Intensive Care Medicine for a couple of years. And I had the chance and was proud to work very close with her, writing the textbook of the ACE-ICM and the consensus of ACE-ICM. And I know her very well teacher, very well in the field. And I'm sure we're gonna enjoy her talking about brain ultrasound in acute brain injured patients. How can we use the brain ultrasound with two wings, the optic nerve and the transcranial doppler? Without any further ado, let us hear from Kairouba.
Hello to everybody, and thank you very much for the invitation. I'm Kairouba from the University of Genoa in Italy, and I'm the chair of the Neuro-Intensive Care section of the ASIC. And now, in the next 20-30 minutes, we will discuss about brain ultrasound in acute brain injured patients. So if you want to start to do brain ultrasonography, this is a quite wrote paper. This is a review with a huge number of supplementary materials with videos, and it describes the methodology, the basic and advanced principle and clinical applications. So I suggest you to have a look at this. And what you will find is basically a description which goes from the basics to the advanced application that today we will quickly discuss. So the difference between brain ultrasonography and ultrasonography in any other part of our body is that there is the skull, and the skull does not allow to the ultrasound to penetrate. This means that what we need to do is to use some windows. The main windows that are used for this purpose are the transtemporal window, which is here above the zygomatic arc, where you can obtain the majority of the information and you can insonate the majority of the vessels which are useful in the neurocritical care practice. Then there is the transorbital window, which we will see with the application on vessels, but also for the evaluation of the optic nerve sheath diameter. The occipital window, which basically allows to assess the vertebral and the basilar arteries and the posterior areas of the circulation, cerebral circulation, and the submandibular window, which, as we will see, is generally used for the definition of the Lindergard index and for the assessment of vasospasm in patients with subarachnoidal hemorrhage. As mentioned, the problem is that there is the bone. So the first point, which is also the first limitation, is that we are not allowed with brain ultrasonography to see all the structures within the brain. What can we see? Again, this is an example of a transtemporal window insonation. This is the position of the probe, and these are the planes which are generally insonated for a normal evaluation in neurocritical care patients. As you can see, the first one is the mesencephalic plane, which is this one, and it allows to assess the mesencephalus. It allows to assess intracerebral issues in these areas and to insonate the Willis circle. On the right side, so here, you have a typical image of this. You see there is the transtemporal window, the temporal bone contralateral, and here the structure here is the mesencephalus. And still more on the right, there is a similar image, but in a patient with the compressive craniectomy. If we tilt the probe 10 degrees slightly upwards, what we can see is the diencephalic or third ventricle plane, where we can have an assessment of the third ventricle. And this is a plane which is normally used to assess again the anatomy, and in particular the presence of hydrocephalus, and to assess the presence of the EVD or other issues which are related to the CSF space. And then if we move even more upwards, what you can see is the ventricular plane, where it is possible to appreciate, this is possible especially in the compressed patient, as you can see, the lateral ventricles and the other structures in the brain parenchyma. So let's start from the anatomy. At the first look, you might probably be confused looking at the anatomy using ultrasound. The first landmark that you need to achieve, to obtain when you want to do an assessment of brain structures is the contralateral temporal bone, which is this structure here. It is hyperechogenic. And when you see this structure, it means that you are in the right place in the temporal window. And within this space, there is a structure which looks like a butterfly or a heart, whatever you want to see. I like to call it the butterfly, and this is the mesencephalus, as I was previously mentioning. Now, again, it might be difficult at the first look, but if you start to compare what you see with your probe and what you see in neuroimaging, such as this is an MRI, you might start to appreciate the different structure and your eye may get used. Same thing for the third ventricle. At the first look might not be so straightforward to look at it. Look, this is our contralateral temporal window, and these are the two structures, two hyperechogenic structures, and this is the third ventricle, inside of which there is the CSF. Again, if we look at it compared with a CT scan, you might appreciate the characteristics and the structures of the third ventricle. And if I now show you this picture here, as you can see here, there is another third ventricle. This is another type of patient. And the patient on my right, on your right, is a patient with a smaller third ventricle. This is a patient with brain edema. And so you have already done with just one figure a differentiation, a diagnosis of an important pathology at patient's bedside. Of course, if you can measure the third ventricle, you also can be able to assess whether the patient has got an hydrocephalus with exactly the same principle that I showed you 1 second ago. And there is some literature regarding this, and there is also a good agreement between the sonographic and the CT measurements of the diameters of the ventricles. And in particular, the third ventricle is quite easy to be insonated because doesn't need any angle correction, and it is depicted in a plane which is orthogonal to the probe. There are some numbers which have been proposed by different authors, and the cutoff of an increase of 5.5 millimeters in the third ventricle has a high sensitivity and high negative predictive value for the need of external ventricular drainage. So in some centers, this is used to follow up the need of closure of the external ventricular drain or the need of removal or insertion of the external ventricular drain. This is a case that we had in our unit, and it is a very clear case. This was a patient with traumatic brain injury, unfortunately a very young guy. As you can see, he developed after the compressive craniectomy a huge, the bone was repositioned, but he developed an important hydrocephalus here. This is the CT, and it's very clear, actually, the presence of the hydrocephalus, but look at these images in the ultrasound. We were able to follow up the patient, measuring the distance and the caliper of the lateral ventricles and also of the third ventricle, and we were able to reduce the number of CT scans for this patient because he had a very nice window. And it's still this patient, the case was then published. These are other images. If you see, for instance, in yellow, if you follow the yellow circle here, this is the CT in the middle, and this here is the tip of external ventricular drain. And using the ultrasound up on the left side, here there is not the tip of external ventricular drain. Then in the second image, you will see that there is the tip. It persists the tip, and then the tip of the AVD was removed. And we were able, for instance, to follow up whether an issue with the drainage of the CSF was related to a malfunctioning or a malpositioning of AVD. The patient itself had another complication, which was a bleeding, which is here in red, and we were able to follow up using, if you follow the red circle in the ultrasound images, you will see here the bleeding, and here the bleeding was sorted out. Still, the same patient unfortunately developed a very important complication, an infective complication, and you can see here there were vegetations inside the lateral ventricles here, and again we were able to follow up the antibiotic therapy administration and effect on the intracranial infection. This is a very good case, but of course, there are many other applications rather than hydrocephalus. One of these is, for instance, the midline shift. Now we have learned how to obtain this kind of image. We are in the diencephalic plane. So this is the third ventricle here, and this is a CT. Now, as you know, there is a rule through which, a formula through which you can actually measure the midline shift, and it is calculated as A minus B divided per 2. And this is something which can be reproduced even using the ultrasound, because as you can see here, if you take as reference the third ventricle, you can measure the line A and the line B, and you can apply the same type of formula. Of course, this is a very important point from a clinical perspective, because as you know, the presence of the midline shift is associated with a poor outcome. So it is possible in this way to follow up the patient and be able to see whether there is a change of a midline shift over time. Is there a correlation with the CT? Yes, there is a correlation with the CT. Of course, this is a nice study from a group of 10 years ago, which demonstrated this correlation. But again, look at these dots, and this graph in general to me means that we cannot use ultrasound to say whether the midline shift is 4 or 3.8, because it might be not precise in terms as a number, but you can say whether the midline shift is improving or is worsening. So it's more about the changes from the basal, and this can allow you to reduce the number of the CTs. Other applications, we are still regarding the anatomy, so not yet discussing about the vessels. Intracranial hemorrhage. Well, of course, this is an example, a lucky example, because as I mentioned before, we are not able to assess frontal hematoma or posterior fossa hematoma. But this is a patient who arrived in the emergency room, and this is a spot of bleed here, and this is a patient few hours later. This is an epidural hematoma, which has exactly the same anatomy and the same structure as in the CT. And this is your mesencephalic view and the mesencephalic plane. This is the mesencephalus. This is the initial bleeding, small bleeding, which then increased and started to have the shape of an epidural hematoma. Even in this case, there is a good correlation in literature regarding the diagnosis and regarding the measurement of the diameter. You see nice good correlation coefficient 0.8, 0.85, with again the main limitation, which is related to the presence of the bone. I mentioned this limitation many times because if you are in a condition where the patient underwent the compressive craniectomy, this limitation does not exist anymore, because this is an example of a brain ultrasonography where basically you have a clear anatomical description and vision of all the structure in the brain. In this case, it's absolutely simple to use brain ultrasonography to assess in a precise way the structures of the intracranial compartment, the presence of bleeding, the presence of intracranial hematoma, and of hydrocephalus. This is an example of a tip of an external ventricular drain in the lateral ventricle. And many authors are suggesting that if you have a patient who underwent the compressive craniectomy, because of the precision of this technique, this should become a new standard of care. And I basically agree, because the literature is telling us that the limitations that we have seen so far when the patient is decompressed are just disappeared. This is the same correlation that I showed you some slides before. As you can see, this correlation is much better, and there is a higher precision, a very high precision regarding the measurement of the lateral ventricles, of the third ventricles, and also of the fourth ventricle in this study. So this means that in this case, we can definitely trust this tool in terms also to be accurate in the definition of the measurement and of the diameter of the different ventricles. So far, we have just used a normal probe with a beam mode, and we have just described what we see in the brain. But of course, brain ultrasonography is very famous for the use in the assessment of a transcranial Doppler, so in the assessment of the flow velocity of the main vessels within the brain. And the methodology is basically the same, so it's a normal ultrasound machine. Now the majority of the ultrasound machine have settings which are specific for brain ultrasonography. This is an example of a patient, a young patient who was undergoing brain ultrasonographic assessment. And what you have to do is just to put the color. So this is the same image that I showed you before. Here you have the mesencephalus. There is the contralateral temporal bone. Once you have assessed the anatomy, as we have shown so far, what you can do here is to start the color. And this is what you see. This is the Willis circle, and it is much easier with this technique rather than with a blind technique. Of course, you have to keep in mind the anatomy, but this is the Willis circle, so you know that this is the middle cerebral artery, anterior cerebral artery, and the posterior cerebral artery. And in this way, you can insonate these vessels and obtain important information regarding what is happening in the brain. Again, with the advent of this TCCD compared to the blind TCD, it's much easier to detect the vessels because you definitely see them. But at the same time, we should not forget the identification criteria for the different vessels. So when we insonate and we put the power Doppler on the MCA, we know that generally we should be at this depth, that we should see a flow which comes toward you with a flow velocity which is generally within this range. And the same is for all the other types of vessels. So we have insonated our vessels and we have a flow velocity, which is a systolic, diastolic, and the mean flow velocity. How can we apply this in patients with brain-injured patients? These are all the potential application of this technique in the neurocritical care settings. One which to me is one of the most important is the assessment of the cerebral autoregulation. What is the cerebral autoregulation? Is the ability of the brain to maintain constant the cerebral blood flow despite the changes of the mean arterial blood pressure. So we know that there is a vasomotor response in the brain. If the systemic blood pressure changes, if the CPP changes, there is a limit which is the lower and the upper limit of autoregulation within which the cerebral blood flow remains constant. And this is important to avoid secondary brain damage because the cerebral blood flow is preserved. We know that this range in young, healthy patients has this shape, so it's quite big. We know that in hypertensive patients, the curve can be shifted a bit to the right. And this is the limit at which we need to pay attention because we know that we have to keep a blood pressure which is higher than this and lower to the higher limit of our autoregulation to preserve the brain circulation. The real problem in the clinical practice is that the curve that we have seen of autoregulation is not like we see it in the books, is more similar to this. So there is a need to individualize the ability to assess autoregulation because, for instance, if you have a patient like this, you might set a CPP of 60, and this is absolutely fine, but this 60 millimeters of mercury might not be enough for the other two patients, and you are setting a bad value of cerebral perfusion pressure. Why is it so important to set a value of CPP which optimizes cerebral autoregulation? Because autoregulation is a mechanism of protection. It protects us from the hypotension, because if we are below the lower limit of autoregulation, you will develop ischemia because you have a reduction of the cerebral blood flow. And on the other hand, you are less protected from hypertension if you go above that limit. And there are thousands of patients which demonstrates that an alteration of cerebral autoregulation is associated with worse outcome. But the current guidelines are not very helpful because they are just telling us, just keep the CPP. And now there is more an idea of preserving autoregulation, individualizing autoregulation. But to individualize autoregulation, we need to measure autoregulation. And to do so, we need to measure cerebral perfusion pressure, and we need to use a surrogate of a cerebral blood flow. And in this setting, the brain ultrasound and the transcranial Doppler is a measure, is a surrogate of the cerebral blood flow, because there is a direct correlation between the cerebral blood flow and the flow velocity that you use and that you can apply and that you can measure using the transcranial Doppler. So one very simple way to assess the autoregulation is just to test the autoregulation. If you have understood the concept, you measure the arterial blood pressure and you do a transcranial Doppler with, let's say in this case, 60 centimeters per second of flow velocity, and then you increase the arterial blood pressure and you see what happens. If you have an increase of arterial blood pressure, but the flow velocity remains quite normal, it means that the patient is autoregulating well, because it means that the cerebral blood flow remains constant. This is what we call a static test of autoregulation, and it can be done at the patient's bedside, but it's basically what the guidelines are telling us to do, because if you look at the CBIC algorithm, at some point as tier 2, it is recommended to perform a MAP challenge to assess the autoregulation and test and set the arterial blood pressure according to this. And it is exactly what I've showed you before. There is another test which can be used, which is the carotid compression test, which is very similar, but this is just an example to tell you that this can be done at the bedside. Then if you are lucky, there are also some software which monitor, you don't need to do anything, they just monitor the autoregulation status of the patients, and this software creates a correlation coefficient between the arterial blood pressure and the flow velocity. And it is the very famous MX, which is the relationship between the changes in CPP and the changes in the flow velocity. And the group of Cambridge has done a lot of research regarding this MX index, which is able to tell us which is the CPP optimal, the optimal blood pressure at which my patient is autoregulating at best. Another very important application in neurocritical care for brain ultrasonography is the presence of the vasospasm. In fact, if there is a reduction in the caliper, which is generally associated with the presence of vasospasm after subarachnoidal hemorrhage, this corresponds in an increase of the flow velocity. So you will see an increase of the flow velocity in the main vessels in the brain. And there is also a good correlation between the amount of the increase of the velocity and the percentage of the narrowing within the cerebral vessel that you are insonating. This is something that we do every day in patients with subarachnoidal hemorrhage patients, but be careful, because what you are seeing is just the flow velocity. So you don't know if this increase in the flow velocity may be related, for instance, to an intracranial issue, so the vasospasm or a stenosis, or if it is related, for instance, to a condition of general cerebral hyperemia. And this is why the Lindergan-Rizzio index is very much used. As I mentioned before, using the submandibular window, you measure the flow velocity in the internal carotid artery. And if you do a relationship between the middle cerebral artery and the internal carotid artery, you can appreciate whether there is a both increase, and this means that there is a hyperemic status, so not related to vasospasm, or if the systemic flow is normal and there is an increase in the velocity in the vessel, which is related to vasospasm. This is what the Lindergan index is telling you, and this is why it is used in the clinical practice. Other important application is the assessment of non-invasive intracranial pressure. You know that the gold standard are invasive methods for the assessment of ICP, but you also know that the patients with invasive ICP can have some contraindications, or there are some side effects related to the use of the invasive methods. So using brain ultrasonography, you can determine the intracranial pressure assessment. One of the most used and elegant methods is the assessment of the optic nerve sheath diameter. From a pathophysiological point of view, this makes a lot of sense because the optic nerve is surrounded by the meninges, and the meninges are within, there is the cerebral blood, the cerebrospinal fluid. So if you have an increase in the pressure in the CSF, this results in a distension of the optic nerve. This is very straightforward. The ONSD assessment for correlation with ICP has been studied first on MRI and on CT. This is a study from Mipinder Sekon, where he found a good correlation between CT, ONSD, and intracranial pressure, and there is a lot of literature regarding the use of ultrasound ONSD. This is how it is done. So it is done through the transorbital window. Pay attention, because you have to use the linear probe in this case, because the visualization is easier. The probe is put on the eyelid of the patient, and this is the image that you can get. And if you measure 3 millimeters behind the retina, here is the part where the ONSD is more distended, and you can get the diameter. Now, literature is clear regarding the accuracy of ONSD. This is a systematic review and meta-analysis. Which obtain a very good sensitivity and a very good specificity of pooled studies put together. But of course, you have to be careful about the methodology, because the structures are very, very, very small. So intra and inter-observer variability are very, very common. And looking at the literature, there is also huge variability in the methodology of doing this. And just a few weeks ago, we published this paper, which is a consensus on critical care medicine, where we decided to standardize, using an international consensus, the imaging and the measurement of ONSD. And this is aimed with the aim to reduce the inter-observer variability. So we are going to do all the same methodology of measurement. Then there are other ways to assess non-invasively ICP using the transcranial Doppler. Again, we come back to our initial evaluation. So we have our systolic, mean, and then diastolic velocity. There are different formulas based on this, which have been correlated with ICP. One of these is the pulsatility index, which is very common and has shown quite nice results despite discordant in the literature, because pulsatility index is importantly influenced by CO2 values and blood pressure values. So it can provide important information, but be careful about the systemic conditions of the patients. And then the group of Cambridge proposed another formula based on the flow velocity diastolic, which was born to measure the CPP, but from this you can obtain, of course, the ICP. And this formula has been tested in the impressive study, obtaining very good values and very good results, with the ability to exclude intracranial hypertension. So again, the concept, as mentioned before, we cannot use this as a number, but we can use this to exclude the presence of intracranial hypertension. The Impressive 2 study, which is a multi-center study, that was the pilot, confirmed basically these results. Finally, it's less known, but just for completeness, you can also consider to use venous transcranial Doppler if you want to assess non-invasive ICP. This is one of the few studies. You see there is a correlation of the venous flow, which becomes pulsatile when ICP increases, and there is a good correlation with ICP. And when we put together all these methods, what we found is that in terms of accuracy, probably the ONSD is the best one. But at the same time, we asked to ourselves whether these methods can substitute invasive ICP, and the answer is basically no, because at the end of the story, this is important from a clinical perspective. If there is a patient which has the indication for invasive ICP, we still should go for invasive ICP because of these limitations, all those that I mentioned during this presentation. So we cannot think to substitute invasive ICP with these methods. But you can use this in many other conditions. This is an example, a case report of a patient with pneumococcal meningoencephalitis, no indication for invasive ICP monitoring. The patient was coagulated and for meningitis, the indication for ICP monitoring are very, very in a gray zone. So we decided to monitor this patient using non-invasive methods. This is the PI. We had the MX index. We had the non-invasive ICP measurement using the formula from Cambridge and the ONSD. And the patient deteriorated and the brain was very, very swollen. And this was consistent within all the non-invasive methods, which were all worsened. And we started to set the therapy based on the non-invasive methods. Of course, this is an extreme case, but consider that this is a case where these methods can really help you. And of course, as we did in this case, but in general, as all of these methods have their own limitations, if you use a multimodal neuromonitoring techniques using a combination of these, of course, the possibility to predict ICP improves a lot. And it has also a prognostic value. If ICP is too high, of course, the risk is that the patient may develop brain death. And as you know, determination of death is based on clinical assessment, but the guidelines are also telling us that transcranial Doppler can be used as an ancillary test, especially if there are confounding factors. And this is the pattern that you will be able to see. This is in the first line, a normal transcranial Doppler. In the second, when ICP becomes as big as diastolic blood pressure, and then you have a reduction and a complete loss of the flow velocity. And this is called also the beacon signal here, when you have a reverberating flow here. And the literature is telling us that there is a very good diagnostic capability of a transcranial Doppler for the diagnosis of brain death. And then last but not least, consider that because of everything I told you so far, brain ultrasound should be applied not only in neurocritical care settings, but also in many other conditions. Like, for instance, think about cardiac arrest, think about sepsis. These are all conditions where you might have a lot of neurological complications, despite the initial issue is not an intracranial issue. So what we propose so far is to add to the focus of trauma, the presence, the use of brain ultrasonography with all the applications that we have described so far, and focus after cardiac arrest. So, in conclusion, brain ultrasound is an important tool for neurointensive care settings because there are a number of very good applications and then can help you to guide treatment. It is easy, quick, bedside. Of course, you have to know the methodological limitations, but it should be implemented in a head-to-toes approach. I thank you for your attention, and if you have any questions, I am absolutely available.
Thank you very much, Dr. Kaira Roba, for this very nice presentation. And you highlighted the most of the important, if not all the important points related to use of point-of-care ultrasound, brain ultrasound, in identifying different related issues to brain issues related to the intracranial pressures and many other things, particularly in subarachnoid hemorrhage and brain death. We have a lot of questions here. Some of them is directly asking about the challenges that the intensivist or the acute care physicians are facing to practice bedside. Do you think, Kaira, that doing a brain ultrasound, either transcranial Doppler or the optic nerve sheath diameter, is really challenging or easy to learn?
Thank you for the questions. I don't think it is much more difficult than any other ultrasound methods. I think that the learning curve for the TCD is around 40 examinations for basic and plus basic, according to the consensus on neurocritical care. And for ONSD is something more than 20 scans. Of course, supervised, of course, with the right methodology. So I think it's much less than, for instance, echocardiography. The problem is that there are less people who are doing it, so you will find a less number of trainers all around the globe, and definitely less courses, less teaching programs, and that's something on which we definitely need to work on.
Yeah, if you remember, when we wrote the consensus of the European Society of Intensive Care Medicine, I think there was no agreement among the experts regarding if the transcranial Doppler and optic nerve sheath diameter to be among the basic skills needed for intensivist. Am I right?
You are right. We didn't obtain the agreement for ONSD. We obtained an agreement only for the pulsatility index based on transcranial Doppler. And I understand now. I think that if we repeat that consensus, maybe something has changed over the last years. But the problem is, to me, really a lack of knowledge of the possibility and of the importance of using these tools. Because if you do a pulsatility index, it means that you are insonating an MCA. So, which is the difference between a pulsatility index and the flow velocity diastolic? Methodologically, is the same. You only change the formula that you calculate from the waveform. So, I think it's just about that.
Yeah. From your experience and personal preference, Kyra, if you advise the junior staff in neurocritical care or in general ICU, which way they go and learn it more to predict the increase in ICP, the optic nerve sheath diameter, which is relatively easier, or the transcranial Doppler, which is relatively, for my opinion, relatively harder to get sometimes in ICU patients. Which one you prefer?
I don't have really a preference because you know, in terms of accuracy, my point is that if the pathophysiology of increased ICP is an increase in the CSF pressure, ONSD works best. If the pathophysiology of increased ICP is a change in the vasomotor response, TCD works best. And if there are also hemodynamic changes, the flow velocity diastolic formula works best. So there is not a best. It really depends on the pathophysiology of increased ICP. So what we recommend is to use as more tools as possible. So use both. And if you have at least two tools who are telling you the same things, you are probably in the right direction.
Thank you, Kyra. Because we have a lot of fellows here following us, so everything is very challenging. If you know how to do it, you get sometimes a lot of information from. And as Kyra highlighted in several of the statements, that sometimes you're left with no options to monitor the brain of your patients. If you have coagulopathy, and you cannot go with invasive, which is the gold standard of ICP monitoring. So what to do? If you have unstable patients to move to radiology suite, what you're gonna do? What other sort of investigation you might have? Of course, point of care ultrasound, bedside, if radiation free, relatively less cost, easy to learn. If you know how to do the study and you use it as part of the puzzles to reach the diagnosis, then it might be useful. So it opened an eye on that this has to be added to the tools in your hand to use bedside. Again, thank you, Ruba, for this very nice presentation and discussion. Dr. Fadel.
Thank you very much. Really, thank you.
Thank you, Kyra. Fadel, you have a question here, which is, what is the rule of N14 on diagnosis of brainstem death? Can you highlight?
For the brainstem, this we are using the N20 to understand this. What is meant by N is negative. 20 is a millisecond, it's a time. So to make the median nerve stimulation or the posterior tibial nerve stimulation, it will take 20 milliseconds to produce action potential as we saw in our clinical scenario. So this is a good prognosis for the cortex or the cerebral cortex. But we have, I read some questions that what is the contraindication of using somatosensory evoked potential in ICU? This is a very important question because it is very simple and we can use, but there is some contraindication, like if the patient have burn, there is a problem in his limb, infection or something like this. Another thing, there is a relative contraindication we should know, like Guillain-Barré. If you know Guillain-Barré have affection of the nerves, so it may produce longer or even absent stimulation of the N9 or N14 or N20. So for N14, we are testing exactly when reaching the N14, which is producing action potential after 14 seconds in a negative way. This is in the brainstem. We are testing the brainstem, but the most important and all the guidelines and even the prognostication tests are testing the N20, which is the production of action potential after 20 milliseconds of stimulation.
Thank you very much, Dr. Fadel. There are maybe 2 or 3 questions about the oximetry or cerebral oxygenation. If you want to comment, and Kyra comment also on this, use of cerebral oxygenation in monitoring, invasive oxygenation or non-invasive oxygenation monitoring. Fadel, if you would like to start.
The invasive about the tissue oxygenation, the probe, which is already the multi-probe that we are inserting one probe, and through this probe we can do cerebral microdialysis, we can do brain tissue oxygenation, which is measuring the oxygen level in the brainstem. And as you mentioned, Dr. Ashraf, that this is the golden standard of neurocritical care monitoring. This is the most important thing. The non-invasive, which is like NIRS, which is near infrared oxygen tissue oxygenation, which is a probe that can be connected to the head, is also, but the invasive is more accurate and it gives more information about the oxygenation and metabolism in the brain tissue.
Prof. Kyra, if you comment.
Yes, I'm not a very great fan of the NIRS because it has a lot of methodological issues, and I don't think it really represents what is happening in the brain. There is a very nice paper where NIRS was put on patients with brain dead and medicine students, and there was no difference in the values. So they were Italian students, so this can be a reason, but at the same time, I think there is a huge risk of extracranial contamination and needs to be taken with caution.
A few years back, we published on cerebral, non-invasive cerebral oxygenation as one of the perfusion parameters in shock, ICU shock patients. And we found very good correlation between the cerebral saturation by NIRS and the reduction in lactate, improvement in central venous oxygen saturation, and an improvement in bicarbonate and other perfusion parameters. So it was helpful, though it was a single center trial. So thank you very much again for Dr. Fadel for this very nice presentation of these case scenarios, and Dr. Kyra Roba for highlighting very important spots of lights on the use of brain ultrasound as a non-invasive tool. And I'm very big fan of the ultrasound, of course, and we're running an online program for a point-of-care ultrasonography, and the week, which is the last week of the advanced module, is about brain ultrasound, both of transcranial Doppler, different uses, and the optic nerve sheath diameter. I give the mic now to Dr. Amr Husseini to conclude and adjourn here.
Thank you so much, Dr. Ashraf, Dr. Kaira, and Dr. Fadel for this fantastic presentation and moderation. And I promise all of the attendees during our one-year Neurocritical Care Fellowship program, we will dive deep in these all of these topics and subtopics that it's open-ended discussion. We need more information, we need more studies, and we need to have a dialogue, not only a monologue. So hopefully during our one-year online fellowship that's accredited by the American Association of Continuing Medical Education, you will get more and more information. For the invasive part of the neuromonitoring, we don't have enough time today to talk about, so we'll dedicate another webinar to discuss the invasive part. And all the attendees should get attendance certificate by next week. And also, you should get a recorded webinar YouTube link by tomorrow. So please stay tuned. We will be in touch. We'll send the information in our Neurocritical Care WhatsApp group. If you haven't joined our Neurocritical Care WhatsApp group, please do. We already shared the link in the chat box. So please join us. And also, you're going to receive a couple of emails and notification from us regarding the links regarding the upcoming one-year Neurocritical Care Fellowship and regarding the registration and the attendees certificates. With that, I again appreciate your presence for more than an hour and 15 minutes, and we'll see you next month. We have on 21st of October, another neurocritical care fantastic webinar focusing on immunological encephalitis, non-infectious encephalitis, and brain injuries. So again, we'll send you more notification about that. Have a good day, good afternoon, good night.
Thank you.
Bye.
Thank you, Doctor.